Assalamualaikum everyone. Our next topic of discussion from First Aid Pathology is acute and chronic inflammation. We will briefly review the differences between acute and chronic inflammation. Basically, acute inflammation is the transient and early response to the injury or infection, as the name suggests, while in chronic inflammation, there will be prolonged inflammation. The main cells that are involved in acute and chronic inflammation are important. In chronic inflammation, there are mononuclear infiltration, which includes macrophages, lymphocytes, and plasma cells. While in acute inflammation, there are basically neutrophils present. Another difference is the time period. It is rapid onset, seconds to minute, and it is of short duration, from minutes to days, while chronic inflammation is of longer time period. These are the basic differences between acute and chronic inflammation. Causative agent include pathogens or injured tissues, while in chronic inflammation there is persistent acute inflammation. Major cell involved neutrophils in acute and mononuclear cells in chronic inflammation. If we see onset, acute inflammation may immediate, and in chronic inflammation it will be delayed. And duration, in acute inflammation it lasts for a few days, while in chronic inflammation it lasts up to many months or years. So it can also be associated with edema, and it represents a reaction of innate immune system, and it is less specific response than the chronic inflammation. While in chronic inflammation, it leads to simultaneous tissue destruction and repair, which include angiogenesis and fibrosis, and it may be preceded by acute inflammation. If we see the stimuli, any infection, trauma, necrosis, or foreign body can stimulate acute inflammation. While in chronic inflammation, there is persistent infection, and an important example is TB. It can also occur in cases of treponema pallidum or certain fungi and viruses, and it involves type 4 hypersensitivity. Autoimmune diseases and prolonged exposure to toxic agents like silica and foreign body can also stimulate chronic inflammation. So the main stimuli are persistent infection, autoimmune disorders, and prolonged exposure to the toxins. If we see the mediators of inflammation in acute inflammation, they include toll-like receptor, arachidonic acid metabolite, eosinophil mast cell, basophils. Inflammasome, what is inflammasome? Basically, it is a cytoplasmic protein complex that recognize the dead cells, microbial products, and crystals, and it activates interleukin-1 and inflammatory response. If we see the mediators of chronic inflammation, the macrophages are the dominant cells in chronic inflammation, and interaction of macrophages and T cells leads to chronic inflammation. There are two main types of cells involved, Th1 and Th2. Th1 release interferon gamma, and Th2 secrete interleukin 4 and 13. Basically, there are two pathways. T helper cells, T helper 1 cells, they are involved in a macrophage classical pathway by secreting interferon gamma, and T helper 2 cells, they are involved in macrophage alternative pathway, which is secreting interleukin 4 and 13. Now the classical pathway is pro-inflammatory, while the alternative pathway is involved in repair, and it is anti-inflammatory. Here the two pathways are shown. Classical pathway is causing inflammation, while alternative pathway is anti-inflammatory, and it is involved in repair process. Next comes the components of acute inflammation. So there are two important components of acute inflammation. There are vascular events and there are cellular events. In vascular events, there is vasodilation, blood flow increase in the vessel wall, and stasis will occur, and there will be endothelial permeability due to contraction of endothelial cells that opens the interendothelial junctions. First, there will be vasodilation of vessels, which will cause stasis of the blood, and secondly, there will be contraction of the endothelial cells, which will cause increased endothelial permeability. So it occurs to bring the cells and proteins to the site of injury or infections. Next comes the cellular events. It includes the extravasation of leukocyte, mainly neutrophils, from post-capillary venules, accumulation of leukocyte in focus of injury, and there will be leukocyte activation. Here is the vessel wall. The permeability will increase due to endothelial contraction, and the leukocyte will come out of the blood vessels. They will go to the site of injury, and there will be leukocyte activation. And leukocyte extravasation has 4 important steps which we should remember. It includes the margination and rolling. Second is adhesion. Third one is transmigration, and last one is the migration, chemoattraction. So we should remember them in order, and we will cover them in detail. If we see the outcomes of acute inflammation, what can happen in cases of acute inflammation? Either there will be complete resolution and healing via interleukin 10 and tumor growth factor beta, or there can be persistent acute inflammation with the help of interleukin 8, or there can be abscess formation, which is the acute inflammation walled off by the fibrosis, or it can proceed to the chronic inflammation, which includes the antigen presentation by macrophages and other antigen presenting cells. It will cause the activation of CD4 plus T helper cells, and last one is that it will lead to the scarring. So macrophages predominate in the later stages of the acute inflammation. Peak occurs in 2 to 3 days after the onset, and it influences the outcome by secreting the cytokines. So within 24 to 48 hours, there is predominance of the neutrophils, while in 2 to 3 days, there is the predominance of the macrophages in acute inflammation, and that is important. If we see the outcomes of chronic inflammation, what can happen is that there can be scarring, amyloidosis, or there can be neoplastic formation. For example, if there is chronic hepatitis C infection, it can lead to chronic inflammation, and eventually there will be formation of hepatocellular carcinoma. The H. pylori infection, it can cause chronic gastritis, and it will eventually lead to gastric adenocarcinoma. So these were the outcomes of chronic inflammation. Next, we will see the important steps of leukocyte extravasation that predominantly occurs at post-capillary venules. There are 4 important steps. First one is margination and rolling. In normally flowing blood in venules, the red cells are confined to the central axial lumen, while the WBCs, they are displaced towards the wall of the vessel. Because of the dilation of the inflamed post-capillary venules, the blood flows slowly. There will be stasis, and more white blood cells assume a peripheral position along the endothelial surface. This process of leukocyte redistribution is known as margination, means the leukocyte goes towards the margin of the vessel wall. Next comes the rolling. Rolling occurs with the help of adhesion molecules that are known as selectins. So there are 3 types of selectins: P-selectin, E-selectin, and L-selectin. There is interaction between the selectins and the ligands, and it causes the loose adherence of the WBCs to the endothelial surface, and it helps in the rolling of the WBCs. Firstly, we will see the selectins that are present on the vasculature, on the endothelium. So the E-selectins and the P-selectins. These are the E-selectins and P-selectins that are present on the endothelium, and their ligands, they are present on the leukocytes. These are the leukocytes, and their ligands are present on the leukocytes. Their ligands are CLI, Lewis X. And if we see L-selectin is basically, it is present on the leukocyte, and its uh, molecule will be present on the its ligand will be present on the endothelium. That is also CLI Lewis X, and it is present on the glycam 1 CD34. So this is the L-selectin, and here this is the glycam 1 CD34. So what happens in first step is that there will be interaction of the selectins and their ligands, and it will cause loose adhesion of the WBCs to the endothelial cells. Because these are the low affinity interactions with the fast off rate, so they are easily disrupted by the flowing blood. As a result, the bound leukocyte, they bind, detach, and they bind again, and thus they begin to roll along the endothelial surface. Like shown here, they have shown E-selectin and P-selectin, and their ligand is shown, that is CLI Lewis X. They are interacting, and because of the loose interaction, they start rolling on the endothelium. So loose binding or rolling occurs with the help of specialized adhesion molecules that are known as selectins, which have 3 types. E-selectins are present on endothelium, and they are upregulated by tumor necrosis factor and interleukin 1, while P-selectin, they are present on endothelium, and they are also present in the platelets. Basically, they are present in intracellular stores in the endothelial cell granules that are known as Weibel pellet bodies. And if there is a deficiency of CLI Lewis X, there it will be known as there will be defective leukocyte adhesion deficiency type 2. So that was the first step, margination and rolling. Next comes the second step, that is tight binding adhesion. It occurs with the help of specialized adhesion molecules that are known as integrins. There are 2 types of integrins shown here: LFA1, MAC1. Its integrin is CD1118, and second one is VLA4 integrins. The ligand for LFA1 and MAC1 is ICAM or CD34, that means intracellular adhesion molecule, while the ligand for VLA4 is VCAM CD106, that is known as vascular cell adhesion molecules. What happens is that the LFA1 or the second one, that is VLA4, they are present on the leukocytes. They are present on the surface of leukocytes, while their ligands ICAM and VCAM, they are present on the endothelium. Their interaction occurs, and there comes the tight binding of the WBCs to the endothelial cells. This was the second step. And if there is deficiency of CD18 integrin subunit, there will be defective leukocyte adhesion deficiency type 1. The third step is the diapedesis or transmigration, which means that the WBCs travel between the endothelial cell and they exit from the vessel wall. It occurs with the help of specialized immunoglobulins that are known as PCAM1 or CD31, that are platelet endothelial cell adhesion molecules. Basically, they are expressed on both the endothelial cells and the leukocytes. So PCAM1, they are present on leukocyte as well as they are present on the endothelial cells. So their interaction occurs, and diapedesis occurs. They help the leukocyte adhere to and then squeeze through the endothelial cells. In this way, the WBCs, they go out from the vessel wall and they pierce the basement membrane by secreting the collagenases, and then they enter the extracellular space into the interstitium. The fourth step is migration, in which the WBCs travel through the interstitium to the site of injury. They go to the site of injury or infection guided by the chemotactic signals. So chemotactic factors include C5a, interleukin 8, leukotriene B4, etc. And these were the four important steps through which the leukocyte go towards the site of injury or infection. So this was all about acute and chronic inflammation and the steps of the leukocyte extravasation.